Welcome to This Week in Neurology. This week we're covering 10 notable papers spanning multiple sclerosis diagnosis and disease-modifying therapy safety, epilepsy pharmacology and access to surgery, and a set of antibody-driven diagnoses that are easy to miss. Let's dive in. We'll start with multiple sclerosis, where the theme this week is that both diagnoses and drug selection are getting more granular. In Neurology, Solomon and colleagues offer a practical review of the 2024 McDonald criteria and what their global implementation will actually require. The substantive changes are worth committing to memory. The anatomical locations that count for dissemination in space have expanded. New paraclinical findings can substitute for dissemination in time, and for the first time the criteria formally incorporate the central vein sign, paramagnetic rim lesions, cerebrospinal fluid kappa-free light chains, and optical coherence tomography. Perhaps the biggest conceptual shift is a new diagnostic pathway for people who are asymptomatic or have nonspecific presentations, but typical multiple sclerosis findings on MRI, alongside the unification of the attack onset and progressive onset pathways. The authors are candid that this cuts both ways. Earlier diagnosis means earlier treatment, but prior revisions were repeatedly misunderstood and misapplied, and misapplication is a documented driver of misdiagnosis. Hence the specific guidance on pediatric patients, older patients, and those with vascular comorbidity, where incidental white matter change is the trap. And they flag a real equity problem. Criteria that depend on optical coherence tomography and advanced MRI sequences are not neutral across health systems, particularly in low and lower middle-income countries. Once the diagnosis is made, the question becomes which therapy, and here 2 papers in Multiple Sclerosis Journal converge on infection risk. Smoot and colleagues used United States claims data to propensity match just under 2,000 people with multiple sclerosis who stayed on either an oral fumarate or an anti-CD20 monoclonal antibody for at least 2 years. By year 2, the fumarate group already had a modestly lower infection rate, but the gap widened with time. From year 4 onward, fumarate-treated patients had roughly a 30% lower infection rate. The pattern matters more than the headline number. Infection rates in the fumarate group stayed essentially flat, while in the anti-CD20 group, they climbed progressively year on year, which is what you would expect from cumulative hypogammaglobulinemia. This is claims data, so residual confounding and unmeasured disease severity apply, but it argues for actively revisiting long-term anti-CD20 exposure rather than treating it as set and forget. In the same journal, Lamida-Consega and colleagues report a sobering counterpoint from a different mechanism. A 61-year-old man with stable multiple sclerosis on natalizumab, who developed acute hemiparesis, had multiple ring-enhancing lesions on MRI and was found on biopsy and polymerase chain reaction to have reactivated cerebral toxoplasmosis. He progressed to coma and died despite antiparasitic therapy. He also carried a low-risk monoclonal gammopathy of undetermined significance. The lesson is that natalizumab's compartmentalized blockade of central nervous system immune surveillance is not only about progressive multifocal leukoencephalopathy, and that in older patients with hematological comorbidity, a ring-enhancing lesion deserves a broad infectious differential before it is called a tumefactive relapse. Turning to epilepsy, which dominates the week, the most immediately actionable paper is in JAMA Neurology. Schubert and colleagues asked a question most of us answer by habit. Which anti-seizure medication is safe in a patient with epilepsy who also needs a direct oral anticoagulant? Using a target trial emulation across an international federated electronic health record network, they assembled just over 9,500 adults on anti-seizure monotherapy plus a direct oral anticoagulant, and compared levetiracetam, valproate, and moderate and strong enzyme-inducing drugs against a pooled lamotrigine or lacosamide reference. Strong enzyme inducers behaved as pharmacology predicts, roughly a 50% higher risk of thromboembolic events, presumably through accelerated anticoagulant clearance, though with less major bleeding. The surprise is levetiracetam, which is the drug most of us reach for precisely because we think it is interaction-free. Levetiracetam was associated with roughly double the thromboembolic risk and about a 60% higher all-cause mortality, with no offsetting reduction in bleeding. Valproate carried higher mortality and roughly triple the rate of intracranial major bleeding. The authors estimate that around 28% of thromboembolic events in this population might have been avoided under a lamotrigine or lacosamide strategy. Importantly, in patients on vitamin K antagonists, the thromboembolic signal was essentially absent, which supports a direct oral anticoagulant-specific interaction rather than pure confounding. This is observational and channeling bias cannot be excluded, but the mechanistic coherence is hard to dismiss, and for a patient on apixaban or rivaroxaban, it makes lamotrigine or lacosamide the more defensible default. 3 further epilepsy papers deal with timing and access. In Brain, Milivert and colleagues assembled an international cohort of 282 individuals with pathogenic KCNQ2 variants and asked whether the timing of sodium channel blockers matters. Carbamazepine and oxcarbazepine were the most effective drugs in both loss-of-function groups, and in loss-of-function developmental and epileptic encephalopathy, starting a sodium channel blocker within the first month of life was associated with earlier seizure offset and with higher rates of attaining major motor milestones. That developmental association held after adjusting for seizure control at 1 month and for total medication burden, which suggests the benefit is not purely a function of stopping seizures. The authors are appropriately restrained. Some children did poorly despite early, correct treatment, so variant severity and other modifiers matter. Still, this is a strong argument for rapid genetic testing in neonatal onset epilepsy, because the result changes the drug you choose that week, not that year. Also in Neurology, Fung and colleagues addressed the contentious question of paternal valproate. Using Taiwan's national birth cohort of over 2.5 million children, with more than 1,700 exposed to paternal valproate during spermatogenesis and 548 exposure-discordant sibling sets, they found no increased risk of autism, attention deficit hyperactivity disorder, intellectual disability, tic disorder, or congenital malformation. The null result persisted when restricted to fathers with epilepsy and in the sibling comparison. Given the regulatory restrictions now applied to men of reproductive age in several countries, this is reassuring evidence from a non-Nordic population, though the authors stop short of calling for a change in practice. Rounding out epilepsy, epilepsia carries 2 contributions on the treatment gap. Stern and colleagues pooled 2 studies of diazepam nasal spray used out of hospital and identified 402 episodes meeting the International League Against Epilepsy definition of tonic-clonic status epilepticus, meaning seizures continuing beyond 5 minutes. About 62% terminated by the 30-minute mark, close to half of episodes terminated within 20 minutes of the dose, fewer than 5% recurred within 24 hours, and a second dose was needed in only 5%. Serious treatment-emergent status events occurred in about 7% of patients. This supports equipping families with an immediate-use rescue medication rather than waiting for emergency services. And Anglo offers a critical review of epilepsy surgery utilization 25 years after the landmark randomized trial. Fewer than 1% of potentially eligible patients are referred, and those who are referred arrive at a center on average 2 decades after seizure onset. Stereoelectroencephalography, laser interstitial thermal therapy, and thalamic neuromodulation have widened candidacy, but Anglot warns against letting minimally invasive options eclipse resective and disconnective surgery, which remain the only potentially curative procedures validated by randomized evidence. Finally, 2 papers on antibodies that masquerade as something else. In JAMA Neurology, Pluvinage and colleagues used proteome-wide phage display in patients with idiopathic myelopathy and identified autoantibodies against CD320, the transcobalamin receptor that ferries vitamin B12 into cells. Just over half of the discovery cohort was positive, with about 45% positivity in 2 independent validation cohorts. Antibody-positive patients had lower bioactive B12 and cerebrospinal fluid, despite this being a central nervous system-restricted deficiency, and a recognizable phenotype. Subacute onset, a normal cerebrospinal fluid profile, and dorsolateral cord signal change on MRI. 5 patients received B12 supplementation with or without immunosuppression, and 4 improved. That is a tiny treatment series, But for a category of disease where 12 to 18% of myelopathies never get a label, a testable and potentially treatable mechanism deserves attention. Alongside it, Panda and colleagues in Epilepsy describe two patients with anti-LGI1 encephalitis, who first presented with sick sinus syndrome and were managed as cardiac patients until the encephalitis declared itself. Anti-LGI1 is largely reversible with early immunotherapy and can cause permanent damage or death if missed, so unexplained bradyarrhythmia with any cognitive or behavioral change should prompt an antibody panel rather than only a pacemaker. If you only have time for one paper this week, make it the JAMA Neurology target trial emulation of anti-seizure medications during direct oral anticoagulant therapy. It challenges the widespread assumption that levetiracetam is the interaction-free safe harbor, and it applies to a large, easily identified group of patients sitting in your clinic today. Here are the key takeaways from This Week in Neurology. When a patient with epilepsy needs a direct oral anticoagulant, lamotrigine or lacosamide now look like the safer default, and levetiracetam should no longer be assumed innocent. The 2024 McDonald criteria enable earlier multiple sclerosis diagnosis but demand disciplined application, particularly in older patients and those with vascular white matter change. Infection risk on anti-CD20 therapy rises progressively with years of exposure, while natalizumab-associated opportunistic infection extends beyond progressive multifocal leukoencephalopathy in older patients. In neonatal onset epilepsy, fast genetic diagnosis matters because early carbamazepine or oxcarbazepine in KCNQ2 loss-of-function disease tracked with better seizure and developmental outcomes. And keep unexplained myelopathy and unexplained bradyarrhythmia on your autoimmune radar, because anti-CD320 and anti-LGI1 are both potentially treatable. That's your roundup for This Week in Neurology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And a quick rating on Apple Podcasts or Spotify helps other physicians discover the show. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.